Good morning. You're listening to Masterclasses in Dermatology Saturday Morning Live. I'm Joe Merola.
And I'm Alice Gottlieb. Great to have you with us.
This is your weekend clinical reset. It's fast, focused, and built for real life.
We'll keep it efficient, practical, and a great start to your morning.
Each session is designed to give you something you can take straight into practice.
We also want to thank our platinum supporters, Eli Lilly and Company and Regeneron Pharmaceuticals, Inc., for making this program possible.
So wherever you're joining from, we're glad you're here.
Welcome to Masterclasses in Dermatology, Saturday Morning Live. Good morning, everyone. I'm Alice Gottlieb, and we're here with Dr. Joseph Merola, and we're going to be talking about the concept of remission, and is it real? Is it here now? What's the future look like? And we're here at Saturday Morning Live, and without further ado, let's bring Dr. Joseph Merola, a great way to start your morning.
Thanks so much, Alice. So I get to be in the hot seat myself here at Saturday Morning Live. I'm excited to talk about remission concepts in dermatology. I think it's a hot topic. I'd like to think it's not too controversial of a topic, but like everything, there's some controversies, and hopefully we'll touch on some of these and make believers of our listeners with regard to different definitions of remission this morning.
So let's get started. What is remission really?
So, I'll take a step back, and I think both of us are probably going to frame this around a couple of our disease states in dermatology, and probably most aptly, I would say, psoriasis. And I'll start by saying we've come a long way. I think some folks can remember, Alice. The days of PASI 50, right, and achieving PASI 50, we moved to PASI 75 as an endpoint target. These days we see a PASI 75 in data, and we're sort of looking for the next thing, and we've moved to PASI 90, even some programs focused on PASI 100 and complete clearance of skin. The concept of remission has been framed of late in sort of two different areas. So one is, this gets into semantics and definition, but the idea of on-treatment remission. There's even a concept of off-treatment remission. If we boldly go even further than that, there's a concept, at least in psoriasis presently, of molecular remission. And I think, the ultimate goal for us is to think, someday about cure. But I think, today we'll probably spend a little bit of time talking about, well, what the heck do you mean by on-treatment remission? What does that look like for patients? Does it matter?
If you had to define remission today in clinic, how would you describe it?
Yeah, so this is an interesting question, and there's where maybe some of the controversy starts. To begin with, put your patient hat on for a moment. I think a patient who's quote unquote in remission wants to see virtually no disease activity or very, very low disease activity. And I think the rub is a little bit, does that mean while on treatment or does it mean off treatment? And we've heard both takes on that. And Alice, I'd like your thoughts as well. I think if you dip into the oncology space, many patients these days, and if you look at current trials, are on therapy and considered to be in, progression-free time and in remission. At the same time, in many folks' minds, they think, well, if I'm in remission, it means I don't need a drug. I think to that end, you're going to hear a little bit about how some of the recent definitions have split on treatment, off treatment, and even used some other terms for that. But I know your thoughts, Alice. In my mind, it certainly means a very low disease state of activity, if not clear. But how do you think about this?
If I had my personal preference, I would say that one has no visible disease, in that case, a PASI 100 off treatment. Um, If one, I think one needs to define it. I think one says one has to define what one means by remission, and then everybody is clear on it. If it means, I mean, one can make the argument that remission on active control is just it just is very highly effective control. It may not be remission has an emotional component too. And so I think it's how it's defined. As long as it's clearly defined, then everybody knows what one is talking about.
Well, stay tuned because we're going to spend a little time on some of the, I think, definitions that are currently floating, at least in psoriasis, and where we've come from and where we're headed.
Would you like to elaborate a little where our concepts of remission in inflammatory diseases are and how it affects psoriasis or psoriatic arthritis?
Yeah, and I can even again take a step back just to say, we've tried to learn in defining some of these endpoints from other fields and other specialties, and certainly these concepts exist in other chronic inflammatory diseases. In rheumatology, we've learned from rheumatoid arthritis where there are remission, low disease activity thresholds that have been defined using a number of different instruments. I think, have learned, Alice and I, obviously both being rheum and derm, have seen this evolve in the psoriatic arthritis arena with ideas around minimal disease activity, very low disease activity, various thresholds of different instruments, DAPSA and such. Before we have our Saturday morning audience fall asleep in their scrambled eggs, I won't go into gory detail about that, but just to say that I think the psoriasis field has evolved, and we have definitions for drug-free remission. We have a really hot off the presses definition of on-treatment remission in plaque psoriasis. And we've started conversations about what this might look like in terms of histopathologic and even molecular criteria. But I think the one that we're here to talk about today, I think for the most part, is this on-treatment remission that the NPF recently put out in a JAMA Dermatology article for your reference. I think April Armstrong, myself, a variety of other authors put this forward. I will tell you, it took a little while, and I think to Alice's point earlier, there were a few moments of controversy around this topic of on-treatment remission. What does that really mean, and what does that look like? And short story long, I'll tell you the definition, which is that on-treatment remission for plaque psoriasis was defined, to your point, Alice, because you said, PASI 100, complete clearance. The definition that came out in the end was either a BSA of 0%, because we knew that BSA is something that clinicians are, more routinely capturing, at least in the US. And it's almost always captured in clinical trials as well and in registries, or an IGA of 0. So essentially clear by BSA or clear by IGA-PGA, a global assessment, while on treatment for at least 6 months. And then there was a 1-year definition and a 2-year definition as well. So I'll pause there. I'm curious to hear your thoughts about that. I think it's quite a stringent endpoint to be asking of patients.
I agree. It is a stringent endpoint. I think that the IGA of 0 or body surface area of 0 or PASI 100 should be identical. Clear is clear. And anyway, so I want to move on a little bit what you think about the idea of a molecular scar, because there have been data shown that while you can be perfectly clear, you can still have evidence of disease activity when you look under the microscope.
Yeah, and that's a great question. I love you brought this up earlier, this idea that, okay, now the skin's clear, right? I mean, this is a pretty incredible time where we have these targeted therapeutics. We're getting people to these really high bar, endpoints. But what does it mean, for the disease sitting under that? Is this a PK effect of drug? Is it actually PD and long impact? And I think that's a little bit what you're getting at. I mean, Jim Kruger and others have sort of talked about this and defined this concept of a molecular scar. If you look, at unaffected skin, at affected skin, expression profiling in those areas, what you often see is, yes, the skin looks really great, looks really clear, but sitting behind there is still some mark that that the skin is not entirely normal, that it reflects a diminished version of an inflammatory plaque. And so sort of behind the curtain is this inflammatory response waiting to recur. And we can see that again in expression profiling. We can see this persistence of tissue resident memory T cells that are there. And the idea being that once we pull drug away, it will come back to the surface. The question of how long it will take to come back is an interesting one. But it does seem, even in our most stringent studies, we talked about things like the knockout study recently, a recent Nature Communication paper from Andy Blauvelt and company that showed when you hit people hard with an IL-23 inhibitor in that case, particularly hard, over, super therapeutic dosing over what we've seen from, clinical trials programs, that a lot of people hit high bar, they stay there for a long while. Even their TRMs, these memory resident T cells, are deeply suppressed. But eventually, it does start to roar back. And so, we're not at the cure stage, but this idea that we could start to look more molecularly at this residual, phenomenon, maybe even start to think about how we can impact that. Is it earlier intervention? Is it combination therapy? Is it, some novel therapeutic that we haven't quite, discovered yet, where we actually hit immune reset? I think, Alice, that's where we start to get to this remission slash, dare I say, cure interface, and hopefully we'll get there at some point for patients in the future.
So far, we've been talking about what the healthcare provider thinks is remission, but do patient-provided PROs give us any more hints about what remission really is? Because at the end of the day, it's if the patient is happy, not if the doctor or PA is happy.
Yeah, no, it's a great point, Alice, and I think we're learning more as we go along. I think some of the more recent definitions are starting to incorporate PROs. The atopic derm one, which I hopefully will be able to cover today as well, did include itch, for example, and trying to get the patient voice and having patients, included in that conversation. Regarding psoriasis, the MPF did do a study not long ago using the MPF survey, which includes over 1,500 patients. What was interesting there is patients considered themselves in remission, interestingly enough, even if they had less than 3% body surface area. About 52% of patients with low BSA, not necessarily zero, perceived themselves in remission. And about 80% of them considered themselves in remission while on active treatment. So I think, even though we all struggle a little bit with these definitions and concepts, I do think there's something to be said about the patients being comfortable with these definitions, even without complete clearance. About a third of those patients reporting had fully clear skin. So I think that was interesting. I mean, at the same time, this idea that eventually we'll get to a point of focusing on PROs, on quality of life and impact. I think that would be a very important goal for us in the future when thinking about remission. But at least, it was reassuring that on treatment control was perceived as remission, and that patients in general were okay with this concept.
So, one caveat to this kind of study is that if patients are never told that their expectation is 100% clearance, then 3% looks great. Okay, so I think it's what a little bit about what environment they're in. In yours and my practices, we're going for clearing, but that's not true for a lot of those patients on that survey. So, and it's certainly not true in rheumatology practices too. So I think it's what expectations they have. If they've never been told they can be clear, they think that'd be great if they have 3%.
Right, right. No, I think that's a great point. And we'll come to it a little later, but obviously it's also hard to call a patient being in a remittive state, a remission state, if their skin's clear, but they have a major comorbidity still active. And I think we'll cover that in a little bit. But I think most patients would be, it's one thing to say your skin's in remission, but if your joints are swollen or you have other manifestations of disease, we obviously have to account for that. So stay tuned.
Yeah, and idiom has been very active in giving patients the predominant voice so that they get heard. It's important because in practice, it's what the patient thinks. It's not what the doctor thinks, it's what the patient thinks and possibly what the insurer thinks. But if we discount the insurer, it's all about the patient. Are you happy with your treatment? Joe, we've just returned from the AAD, and I understand that remission is a hot topic there now. So could you please enlighten us on what's new in remission?
Yeah, so a couple of really interesting posters there, and the reason I think it was exciting is that we're seeing some of the definitions we just mentioned, the NPF on treatment remission, for example, actually start to be used, having data applied to those definitions. So there were two posters that stood out to me I wanted to bring to the group. One of them was looking at Bimekizumab, which is an IL-17A/F inhibitor. They looked at their data through this lens, this remission lens. They did do a comparative take versus some other drugs, but I wanted to focus on one panel in particular, which is they looked at the on-treatment remission definition and they applied DLQI-01. So, this is really, at least in theory, this is, no minimal to no impact on patients' quality of life. And they took a look over 52 weeks to understand, for those who were in remission versus those who were not in remission, what's the difference look like essentially. And, if you look over the course of a year, essentially 56 days, almost 8 weeks worth of time, patients were in the remission state and experienced DLQI-01, more so over those who were not in remission. So we brought patients, 8 weeks of more happiness, if you will, over the course of a week. Sort of an interesting analysis. I think what it says is it's just that it matters, that patients care, and that, this remittive state matters. So that was one thing. The other one that we saw was from a study looking at just happened to be Guselkumab, I would say, in this case, highly effective targeted therapy. And when you look out 3 years, even 5 years in some of these studies, first of all, a near majority of patients were able to meet this on-treatment remission definition using these highly effective newer therapies at early time points. And if you look out, long, 3 years, 5 years, in their study, upwards of 40% of patients were able to maintain an on-treatment remission at 3 years, at 5 years. And I think it just says, that with our newer, highly effective targeted therapies, we're hitting these high bars. So I think for me, it's encouraging to say that these remission definitions are not pie in the sky. They are achievable in psoriasis. And maybe it starts, as a pivot point as we talk about other disease states, and where we are. I'll probably share with you a little bit about some work in AD, but I may pivot back to you, Alice, for a minute, just to say, this is a place where I bet we would love to be, for example, in HS. You're an HS guru. I think one of our upcoming Saturday morning lives, stay tuned, is about HS and HS updates. For you, you've seen the psoriasis revolution and these high thresholds. Is this real world in HS, or would this be meaningful in HS? What would it look like in HS?
No, I'll give you a spoiler alert There's I mean, we're not, let's be honest, we're not at, 100% control, but there is a concept being brought about called inflammatory remission, where somebody has um, no abscesses, no draining tunnels, and no nodules. In this case, this was with sonelokimab at week 40, and about 25% of patients achieve it. So this is beginning to be a definition of some sort of remission. In this case, it's called inflammatory remission, and we'll probably be seeing more of that.
Yeah, I mean, this is a good place to be in 2026 that we're having all these conversations about, deep, low disease activity states, remission, et cetera. And I will say the NPF has even pushed, National Psoriasis Foundation has even pushed a cure concept. I know we're not quite there yet. If we have time at the end, we might be able to, dream together about what cure looks like for some of these diseases.
So, Joe, what do the remission teams discuss about when one could argue that this is just very good PK/PD, that you're not changing the natural history of the disease, you just have extremely good agents, and so how does and I still actually wonder about that. I'm not sure we've shown that we've really changed the natural history of the disease.
It's a good question. I mean, I think, again, depending on how we want to look at this, the idea that the effect far outlasts the half-life of the drug, I think, suggests that we are having some deep impact on disease. I mean, I think a little bit with the knockout study, as we mentioned at the beginning, this idea that you hit hard, you hit early, that might be part of it. I think another, interesting data set that's come out, not, in the fairly recent past is the GUIDE study. That was a study taking people who were super responders and or very early in their disease course. And if you look at very early disease duration, ultra short as they defined it, disease duration, for example, those patients seem to be able to have not only a very deep response, but their responses last long after treatment withdrawal. So again, I think there's some suggestion that yes, we are having a deep immunologic impact beyond just PK of drug. Whether we are though getting to the point of, hitting reset or wiping out the disease underlying, I think is sort of the next frontier. I don't think we're quite there yet. And that's where we're starting to border on the longer term off treatment remissions or even frankly cure, or as you said before, molecular remission. So I hope we'll get there, but I do think that the PD and at least the effect is outstripping just the PK of these drugs.
All right, so I think we're now going to show atopic dermatitis, right, Dr. Merola?
Yeah, so we'll shine a little light on AD because I think essentially, we are probably many years behind where we are in psoriasis. It's safe to say. I think many of you know the AD, current treatment landscape is expanding. The emerging pipeline is expanding, which is quite exciting. So the idea that we're going to now have this bold discussion of low disease activity and remission in atopic derm, I think is exciting. I think it's also, aspirational, but I think, as we move towards some newer mechanisms, we may start to see and have an opportunity there for, to start to look at some of the existing data or the data that's coming in this space through this lens. So I will just highlight really quickly, I was thrilled to be able to lead this International Eczema Council consensus on low disease activity and remission for atopic dermatitis, along with many colleagues through IEC. And, I think, let me start by saying, we said earlier, we've learned from other fields. Rheumatology in particular has had these, multiple threshold sort of definitions, low disease activity, very low disease activity, et cetera. The two things I'll point out for atopic derm, we were able to get consensus around essentially four definitions: low disease activity, very low disease activity, in place of, and I think, an advancement and some innovation in place of on treatment remission, because again, there's been a little bit of controversy around that term. The term has morphed here to be on the drug complete control. Okay, for better or worse, we could debate that, talk about it. And then there's an off drug remission, which I think is less controversial. The definitions are based on, without reading them all to you, they're now in press, by the way, in JAMA Dermatology, hot off the presses. You can review it for yourself. But essentially, it's modular. There's a disease state in signs that's measured either by the IGA, the VIGA-AD, or by an absolute easy cutoff. And then there's also a modular component of symptoms that's measured by PPNRS, so essentially itch thresholds. And then there's a duration for these, right? So is it at 6 months, at 12 months? And so, I won't read them all to you now, but to say that, we now have this definition set. I think hopefully it will help serve the field. We'll start to see how many of our different drugs and drug classes perform based on these definitions. And then I can tell you that in parallel and moving forward, there's also an effort to take an even deeper dive, back to Alice's point earlier, into patient-reported outcome measures. And so they're going to start to look more at patient symptoms and impact over time and see how we can start to line these up for atopic dermatitis. And, we see it for AD. I can tell you that behind the scenes, there's just starting as we move into connective tissue disease. We've done a lot of work in cutaneous lupus, Vicky Worth, Ben Chong, Alice, myself, but both through Idiom, through Lupus ABC, a variety of different groups are starting to look at not just outcome measures for trials, which has been a big topic in skin lupus, for example, but even low disease activity there. Alice mentioned HS. I think this is going to become a theme over time, and I hope one that both pushes our limits, that we look at, again, for inspiration, but even more so that we, start to actually be able to achieve with newer therapies as they come along.
Rheumatology has embraced remission for years. So what have we learned from that field, which is near and dear to both of our hearts? And are there things dermatology should adopt or should avoid?
It's a great question. I think rheumatology has been ahead of the curve on this, from rheumatoid arthritis, ankylosing spondylitis. In our world, as you well know, PSA has several low disease activity and remission definitions. I think the one we most frequently see is either the MDA-VLDA, which is a sort of Boolean remission criteria where you check off, how many out of 7 items, how many do you meet? If it's 5 out of them, it's minimal disease activity. If it's all 7, it's very low disease activity. And there it's also important because there's many domains of disease, if you will, right? It's skin, it's peripheral joints, it's entheses, it's patient-reported outcome measures. There's DAPSA, et cetera. And so, I think there are pluses and minuses there. I know, that, for example, Alice and I have had this conversation for many years, that at least in theory, with MDA, one can be in minimal disease activity and still have, substantial skin disease activity, which most of us would agree is not minimal disease activity. I think we've come out discussing that for some time. I will say to that end, we have tried to move the needle forward a little bit more. The NPF I mentioned had published this on treatment remission for psoriasis. There's now an ongoing effort looking at similar concepts for psoriatic arthritis. And so far, at least, there's just a first round of Delphi going out, really focused on a domain framework. What that, we hope will look like is low disease activity, maybe learning from what we just learned in atopic derm. This is how we sort of cyclically iterate and teach each other. Maybe having a concept of on-treatment complete control, again, in place of that on-treatment remission concept. Ability to discontinue treatment, in an off-treatment remission definition. This is ongoing. Again, we liked the modular nature of what we learned from atopic derm, so looking at clinician-assessed signs looking at patient symptoms. And then, I think trying to innovate a bit here, perhaps over time, even looking at imaging, ultrasound, for example, MRI. Might we incorporate imaging into these definitions a little bit in the same way we were talking about histopathologic, remission or molecular remission, to get to a point where we can start to really define remission and complete control over time. It's a little bit, again, I think some of these are ready for prime time. I think some of these may be definitions that we hope to have a need for as the field evolves over time. But I may throw it back to Alice as well, because I think, here, we're doing this effort. I'm fascinated to see what comes out of these definitions. So Alice, I guess a little bit, as we think about, the scope of these definitions kind of, expanding, right? We're now looking at different domains of disease and such. At what point do we, is it realistic do you think to I don't know, frame that scope? I mean, do we include now, as we learn about comorbid obesity, cardiovascular disease, et cetera, can we call someone in remission if they still have elevated CRPs? Where does that stop? And then I guess the other question I'd have is, based on the conversation we just had about the different potential components of the PSA effort, or even imaging might be brought in, what are your thoughts, with regard to ultrasound and other imaging? Am I in remission if I feel good, but my Achilles heel is still lighting up on ultrasound, for example, for PSA?
So I think with both PSA and HS, we have to look at earlier disease, because once they get damage, the patients will remain symptomatic because you can't undo some of the damage that has been done, whether it's in HS scarring or whether it's in permanent joint damage and psoriatic arthritis, for that matter, rheumatoid arthritis too. So I think, look, in psoriasis, we have the luxury of looking at late stage disease. We do not have that luxury there. In regards to the other comorbidities, some comorbidities are pretty common. So diabetes is a common disease, hypertension, obesity, a lot of these things are common. Whether they are directly related to the pathogenesis of psoriasis, psoriatic arthritis, whatever, I don't think so. I think it's multifactorial. So to define it as part of the remission is, I think, generous. But the other factor that I'm a little concerned is access, because I live in a world where patients are poor or Medicare, so they don't get the advantage of some of these coupons that commercially insured patients get. One could imagine that if an insurer wants to deny care, they could call a patient a non-responder if they're not in the definition of remission, that whatever is decided upon, so that it can be used against access for the patient. So I say when we roll this out in practice, we have to be careful so that the insurer cannot use it to deny care.
That's great. And so I guess, I mean, I think we're hopefully have a little time to talk about, the future next, but I think it's safe to say at least that remission in psoriasis for the time being is probably not just aspirational anymore. I mean, I think as we've talked about from the AAD data, from some of the survey and registry data, we've seen that this is now at least measurable, it's testable, it's certainly trial relevant. I think we talked about, and you touched on this idea that we need some more mechanistic plausibility, right? We need translational data to understand the molecular piece of this. And we may need over time regulatory buy-in. I'd say, we need FDA and others to actually accept some of these definitions if we're going to see them appear in label and such over time. But it's not aspirational, at least for psoriasis. I'm hoping that it starts to come to some of our other disease states before too long.
So we've talked, especially with psoriasis, that you can clear a patient with psoriasis, so you can't find it no matter wherever you look. Well, if one takes it one step further, can one talk about cure? What does that mean? And how far are we away from that?
Yeah. Yeah, I mean, it's a fascinating topic. I know, again, we were being a little psoriasis centric, but a number of years ago, the NPF started this remission and cure. goal. And I have to say, we're getting our heads around the remission. I think we're not quite there for cure. But what's interesting is there've been a limited number when we did a systematic literature review around some of these concepts and topics. There have been some case series, about interventions such as stem cell transplant, where I'm not suggesting we're going to be doing that for psoriasis, but just to say people have gotten them for other reasons, and their psoriasis has never come back, right? So there are scenarios you can imagine where the immune system is truly reset, and then that's a quote unquote cure. In the guttate psoriasis arena, there have been a number of series where either very early intervention, either with things like antibiotics facing strep, and or some of our targeted biologics even used very early in the disease have seemingly kept patients away from a flare or recurrence for years. So I think those are intriguing, sort of mechanistically intriguing. Doesn't help our chronic plaque psoriasis patients, but my thoughts would be that in the relatively near future, hopefully, we're learning more about early intervention / prevention. Might we even get to a point of looking at high risk people and doing something preventative? I think we're getting more clever about novel mechanisms and combination therapy that might be helpful. And then, if we really want to be futuristic, pie in the sky, we certainly, there's CRISPR and all these things now that may modify genetic risk. We're talking, far into the future, but, sort of interesting, and maybe future approaches will actually make, cure a thing. I think to Alice's point earlier, I think a definition of a cure, if we think remission is a stringent endpoint, for me at least, cure means the patient no longer needs any medication at all. I think it means that they're losing even the risk of and the fear of recurrence of psoriasis, and potentially even its comorbidities. I know that's sort of a bold ask, but so I think, Alice, with that, we've covered a lot. We talked all about how we've come from PASI 50 through remission topics. We even touched on cure. I think that's about as aspirational as we can currently get, both in psoriasis and atopic derm, connective tissue disease. So I hope folks find this intriguing, and maybe even it will trickle down to our practices at some point. For the time being, I don't think we're withdrawing therapy from these patients. I'll mention one last thing, if I may. There were a couple posters at AAD that showed us that even when patients responded really, really well, and we withdrew their therapy, that if we eventually go back on therapy, they often don't respond the way they did before they stopped the therapy. They don't get back to that same level. So I don't think we're at an era where we can really withhold or do as needed dosing from patients. So I welcome your closing thoughts on the topic, and then maybe we close out this Saturday morning live conversation.
So I'm thrilled that we're in an era where we can talk to patients about being clear, and I'm also thrilled to be talking to patients with psoriatic arthritis, that you can prevent their real disability, joint destruction. When I was a rheumatology fellow, one saw lots of different kinds of canes and different kinds of chairs and many crippled patients. You don't see that as much anymore. And that's true advance. And my mother, blessed memory, benefited from that with psoriatic arthritis. So I'm thrilled to be living in this era now. And I'm hoping that if I don't see the cure, that Joe will.
Thanks, Alice. All right, Alice, thank you so much for that. She had me in the hot seat. She went easy on me, I think. So thank you. Hopefully folks enjoyed the topic. Coming up next, some really great topics upcoming. We have a non-CME session on adjuvant treatment with Libtayo for patients with cutaneous squamous cell carcinoma who are at high risk for recurrence, after surgery and radiation. We then have a CME session with Dr. Andy Blauvelt, who's going to be talking about transforming psoriasis care with oral IL-23 therapy and the next frontier in patient-centered care. For those of you who attended the AAD, you know that that is a major hot topic with lots of oral therapies coming into the space. And then we have optimizing the medical management of locally advanced BCC. Lots of topics upcoming. Please stay tuned, and even some time for Q&A at the end. And lastly, if you enjoyed our conversation today, on May 9th, Alice and I will be, for Saturday Morning Live, this little coffee talk session in the morning. We'll be inviting a guest to talk about itch and atopic dermatitis. Huge, huge hot area, May 9th. So stay tuned. And Alice, want to take us home?
Thank you very much for tuning in, and we loved spending Saturday Morning Live with you. Thank you.